Welcome to the Ashby Village Science and Ideas Group. My name is Joe Ebinger, and I help coordinate this group's events with the help of our co-host and tech expert, Hillary Naylor. All of our members have varied educational and work experience backgrounds, but we all share one common interest in science and new ideas. We currently have over 60 members in our group and another 90 on our guest list. We meet via Zoom on the second Thursday of every month from 3 o'clock until about 4:30. We have a different guest speaker each month who speaks on a topic related to science and ideas. We rely on our science group members, all Ashby Village members, our invitees, presenters, and others for ideas about new speakers and ways to connect with them. Besides our presentation today, we are actively recruiting speakers who might present to us in the coming months. Here are a few upcoming presentations. On March 3rd, Roger Newman, a retired anthropology and history instructor and one of our group's founding members, will make a presentation on the evolution of beauty, how birds get their colors, their songs, and their displays. On April 13th, Associate Professor Seth Finnegan, who is a paleobiologist and geologist, will speak to us on mass extinctions and ancient climate catastrophes. We invite all Ashby Village members to join our group. Others interested in Ashby Village and our presentations are always welcome. A quick commercial: Ashby Village is a 501c3 tax-exempt nonprofit organization. Please consider a donation via our website. Today, we have Dr. Jonathan Swartzberg, who address the state of the COVID pandemic, the current circulating variants and subvariants, diagnostic tests, treatments, and prevention. Dr. Swartzberg was born and raised in the East Bay, and Cal is his undergraduate alma mater. Practiced internal medicine and infectious diseases in Berkeley until 2001. He has spent many years teaching about infectious diseases at UCSF and UC Berkeley and has been a professor at UCB's School of Public Health since the 90s. Currently, he teaches several classes in the School of Public Health and is the editor of the UC Berkeley Wellness Letter. And with that, I now present to you Dr. Swartzberg. Welcome.
Thank you very much, Joe and Hillary. And it's great to be back talking with you. As Joe said, I will be speaking to you with a PowerPoint presentation for probably about 50 minutes, and that should leave a lot of time for questions, which I'm happy to entertain. So I'm going to share my screen with you now.
It's a Bruegel painting.
Yeah. That's just what I said, Audrey.
Oops, I'm going to mute myself. Sorry.
All right, let's get started. Yes, that's a Bruegel painting. So this is a big agenda, but I'm going to dip into lightly all of these topics. First, I want to just talk briefly about 3 years that turned our world upside down. It's been almost exactly 3 years ago since all this started. Then give you a current perspective of the pandemic, talk a little bit about how the United States has done over these 3 years, and then talk a little bit about the variants to bring you up to date with that. I'd like to clarify some questions that so many have about the antigen test versus the PCR test, and so I'll talk about that with diagnosis. And then talk a little bit about treatment, outpatient treatment, what should be your considerations. And of course, prevention is the name of the game, and what are our tools in that toolkit, and then briefly talk about what the future will look like. Just as a spoiler alert, the answer to that last question is, I don't know. This is a depiction of what happened in New York City in the spring of 2020. I'm sure you all have in your mind's eye, it's indelible in my mind, what happened in New York. The top graph shows the hospitalizations and the bottom, the deaths. And at its zenith here in early April, New York was averaging about 600 deaths a day, Right now, the United States is averaging 450 deaths a day. And that was New York City itself. And these are just some images that remind us of what those very, very dark days were like in the spring of 2020. City streets empty, the hospital ship comfort in New York's harbor to help out with hospitalization. Fortunately, we didn't need to use it very much. And emergency room at Mount Sinai, and a typical ward during the height of the pandemic in Brooklyn. So what is the state of the current pandemic? I think the overall answer to that is it depends. And it depends upon how you're looking at the pandemic. If you're here in the Bay Area or in California or even in the United States right now, you'd say, gee, the pandemic is looking much, much better. And it certainly is. On the other hand, if you are in Japan or South Korea, or especially if you're in China right now, the pandemic is looking like it's just going full force and is a disaster. I mention this because a lot of people are making pronouncements about what the state of the pandemic is and where it's going right now. And I think it's very difficult for us to answer that question looking from the perspective of where we are living, or our home country. The pandemic, while the numbers are declining worldwide, they are declining slowly. Deaths remain very high. And I don't think there's any evidence that this virus is through with us. This just looks at, on the left-hand side, the European Union. This is where the European Union is right now in terms of cases and in terms of deaths. And as you see, the European Union, the cases may be leveling off right now, and certainly they're at a level that are much lower, for example, than a year ago in January and February, when it was the Omicron pandemic was full force. And the numbers of deaths, while low, have been lower in the European Union during the pandemic, and they are increasing a little bit. This looks at Japan in the blue and South Korea in the red, and they're both seeing an upsurge in cases. Now, the upsurge is much less than what we saw in the summer, and certainly what we saw in those countries, especially in South Korea, in the surge of Omicron in the winter of last year. And in terms of deaths, we're seeing an increase in cases, and somewhat of a desultory pattern in South Korea, but certainly an increasing pattern in Japan. And then the state of the pandemic in China, and this is the best I can answer this. We know it's devastating. We know that there have been a lot of deaths and an awful lot of hospitalizations and a tremendous amount of misery. But we don't know how much, because China has not been forthcoming with information, or at least very little information. So without trusting the numbers, we can address a couple things about China. One is that, to answer the question, why is this happening now? Why has it become a really just a crisis in China? And I think the answer is in these three responses. One is that China has an inadequate immunity wall. There's a tremendous amount of societal distrust, and the country as a whole was very inadequately prepared. And I put this picture on the right-hand side. This was China early on in the pandemic, where I remember being just awestruck by the fact that they built 2 large hospitals within a little less than 2 weeks. So they certainly, it was a very robust response, something that I can't imagine happening here in the United States. But I'll come back to that. In terms of an inadequate immunity wall, what I'm referring to is that their population does not have much immunity to this virus, and that's because, as you all are aware, China locked down for much of the pandemic, and they had a remarkable record in terms of the numbers of cases and the numbers of deaths. For the largest country in the world, it was truly remarkable. But the population paid an enormous price for that, as I suspect you're aware, in terms of quarantining, in terms of even being able to leave your home, in terms of isolation. It was a very painful experience for the people who lived in China at that time. So the inadequate immunity wall is because not only were people getting infected like they have been here all along, but their vaccines, they did not have a very good vaccine program, and the vaccines that we're using, primarily Sinovac and Sinopharm, were not very effective. And they would not import vaccines from the West, unfortunately. So when on December 11th, I believe it was the 7th or 11th of last year, that China lifted all of their precautions and essentially let it rip. It did rip. And it really, the virus just passed through the Chinese population very, very fast. I think it may be starting to quiet down a little bit now, but I'll show you some numbers that will be very striking. It's also important to note that a large percentage of the Chinese population is elderly, and they were amongst the most unvaccinated of the population. So it was the population that was ripe for this virus in terms of the virus easily finding a home in human beings. There was also a tremendous amount of societal distrust, primarily reflected in a lot of mixed messages that the population was given. And there was inadequate preparation. There was inadequate preparation in terms of hospitals, healthcare workers, medications, and vaccines. It's unfortunate that China did not use that period of time, almost 2 full years, to be prepared for when they would lift the restrictions. If they had prepared for it by having adequate healthcare force, having adequate medications, immunizing the population, none of this would have happened, and an awful lot of lives would have been saved. One of the modelings, there have been several modeling studies that have been done. This is a representative one. The authors did this in late December. They estimated that there were already over 100 million symptomatic cases. They estimated that there have been 2.7 million ICU admissions, and over the first 6 months of this year, they estimated about 1.5 million deaths in about a 7-month period of time. Other modeling studies have shown a low figure of about 750,000 deaths over 6 months. And this one was 130 million. So somewhere in an enormous number of people. There was fear early on, actually fear for a while about all these cases, that this would be a perfect opportunity for the virus to develop new variants that could then spill over from China to the rest of the world. As of this point in time, we have not seen that. So that's very encouraging. And there's been tremendous economic disruption in December and January because of the pandemic. So China is having a very tough time right now. How has the United States done? This is just looks at the deaths per capita by county in the United States. And the darker the colors, the higher percentages of deaths. California has done relatively well compared to primarily the southern states, but also some of the Midwestern states have done much worse in terms of deaths. In terms of just looking at the numbers of cases over here and the number of deaths over here, the United States right now is right about here, around 35 to 40,000 cases reported. But these numbers, I think, are meaningless because we're doing a fraction of the number of the amount of testing that we were doing just 12 months ago. And that number is continuing to drop and will dramatically drop after May 11th when the state of emergency is lifted. If you look at deaths, there's something interesting that's going on. While the cases over here suggest that, well, we haven't reached a nadir of cases, we did in March, April of last year, and we did in July of 2021, in June of 2021. We are at a low level of cases, but the numbers of deaths have remained fairly static, not real high, but also not real low. We're averaging right now about 450 Americans dying per day. And if you multiply that by 365 days, if things don't change, we're talking about 140, maybe 150,000 Americans will die. Now, I'll give you some numbers in a little while to compare that to the previous 3 years. So how has the United States done? Not well compared to the rest of the world. We have roughly about 13% of the world's cases, but we're only 4% of the world's population. In 2021, we had 18% of the world's cases. We have about 14% of the world's deaths. This was 2022 data. In 2021, we had 16% of the world's deaths, but still only 4% of the population. So the United States is not a poster child for a country that has handled this pandemic well. And if you look at mortality rates in the United States, I mentioned that it's a guess what we're going to have this year, 2023, somewhere in this range, perhaps, unless something dramatically gets better. In 2000, there were 350,000 Americans who died. In 2021, it's estimated about 475,000. In 2022, about 265,000. So the numbers are coming down from its zenith at 475. These numbers are not accurate. They undercount by a very large amount the actual number of deaths from COVID, and I'll go into that in a moment. Right now, COVID is looking to be around the fourth leading cause of death in the United States. Excuse me, right now it's closer to the third leading cause. In 2023, it probably will be about the fourth leading cause of death. And it's particularly poignant to recognize that until February of 2020, COVID played a zero role in deaths. There was no COVID here in the United States. Why did we do so poorly, particularly in the first year? Well, we didn't have an immunity wall here. No one on the planet had an immunity wall. There were no vaccines, and no one had ever experienced COVID before. So this was a virus that had a home in every Homo sapien on this planet. We were very, very poorly prepared for a pandemic. And that poor preparation goes back at least 3 decades of underfunding of public health. Especially since 2000. This spans both Republican and Democratic administrations. So this virus reared its ugly head up at a time when we were very poorly prepared from a public health standpoint. In the first year of the pandemic, we had horrific leadership. As a matter of fact, it was destructive leadership, in my opinion. And this country has no healthcare system. And because of that, there was suboptimal access to care, particularly for underserved people in our society. Let's turn now to some clinical aspects of COVID. There are many, many diseases that can clinically mimic COVID. It can cause just the sniffles. It can cause an asymptomatic infection. It can cause something that looks exactly like influenza, or it can cause something much more severe. There's really no way that the patient can determine what they've got, nor is there a way that the doctor can make a clinical judgment as to what a clinical statement as to what the patient has. It requires a diagnostic test because many viruses and some bacteria can mimic what we see with COVID. A couple things further to say about that. One thing further to say about that is that COVID, in spite of what you may sometimes see on the internet, COVID is a very different disease than influenza, and it is a much more severe disease than influenza. COVID is a multi-system disease. We think of it primarily as a respiratory tract disease, but this virus can and does attack most organs in our body. And COVID causes both short and long-term problems, and I'll talk more about that in terms of long COVID. But COVID also causes a hypercoagulable state, where our blood just clots much more easily, and this can persist for up to a year. And we see more strokes, heart attacks, and blood clots in the veins that can go to the lungs, pulmonary emboli, because of that. This has a lot of stuff on it, but let me try and make some sense out of it for you. If we look at the COVID death risk ratio by age, so this would be 18 to 39 would be the reference point of 1. Then a 40 to 49-year-old person has about twice the risk of death. If we look at people in our age group, 65 to 74, and then going up, 65 to 74, almost a 7-fold greater risk than somebody 18 to 39. And then 75 to 84, 8.5 times the risk, and 85 plus 10.6 times the risk. The greatest risk factor for doing poorly if you get infected with COVID is being older. And it really starts becoming very significant around age 50, and then just ramps up from there. There are also comorbidities, meaning that if you have, for example, obesity or diabetes or chronic kidney disease and so on listed here, it does increase your risk. Nothing like the increased risk with age, but you see, for example, if somebody is obese, they have a 1.3 times greater risk than somebody who's not. And it just goes down the list like that. So comorbidities play a role, not as important as age, but play a role. And then if we look at, and older people have, of course, more comorbidities. And if we look at the relative risk ratio, death risk ratio, if you have one comorbidity, you have 1.5 times the risk, but then the numbers go up pretty dramatically as you add on comorbidities. And I think this plays a significant role, of course, in the aging process. So the bottom line to this slide is the major risk factors for not handling this virus well are: number 1, age; number 2, chronic underlying problems, health problems; and number 3, having multiple of those chronic underlying health problems. There's also been a lot in the on the internet and in the newspapers that I'm talking about excess deaths. And there have been some people who have been saying that there haven't been any excess deaths, and that's just not true. If we go back just in the last year, January 2022 through January 2023, here would be this dotted line would represent the expected number of deaths. And the expected number of deaths are based upon data in the United States from 2013 through to the beginning, before the beginning of the pandemic. So it's what you would expect with the population the size it was at the beginning of the pandemic, how many people you would anticipate dying. And almost every year or every month during the pandemic, we've seen more people than we would have expected to die. And you see this here in the hashed purple of COVID deaths. So there has been an increase of deaths, and these often are not counted in the numbers of cases of deaths that I showed you earlier. So that's why I think those numbers that the CDC publishes are grossly underestimating the actual number of people who have died of COVID. And if there's time, we can talk about why that might be. I'll just throw out 4 hypotheses. One is that the pandemic, for many people, delayed care. People were reluctant to get care, to go into the doctor's office or the hospital or the clinic, et cetera. There were indirect effects of pandemic restrictions on people, which played a role in delaying care. There's the post-acute consequences of COVID. I mentioned the clotting phenomenon and long COVID itself, which I'll talk about in a moment. And there's some evidence of persistent immune dysfunction, at least for a while, that may play a role. These are hypotheses to try and explain why we're seeing excess deaths, maybe not reported as directly attributable to COVID, but probably related to COVID. For example, we've seen a lot more heart attacks and strokes, probably related to people not getting screened appropriately and treated appropriately. We've seen more people with diabetes out of control, many more examples like that. So I was talking about immunity. What is the best immunity? This question comes up all the time. And the best immunity, in my opinion, is getting vaccinated. And the reason I say that is because then you don't have to take the risks of getting COVID itself, which gives you very good immunity. So previous infection gives very good immunity. There's a debate as to whether it gives as good immunity as vaccines or comparable immunity to vaccines. There's really no substantial data to support that it gives you better immunity. But both give you very good immunity. And the best immunity you can get is having had COVID and having been vaccinated. We call that hybrid immunity. Unfortunately, with even hybrid immunity, that immunity does wane over time, and I'll come back and talk with you about that. So let me just briefly talk about long COVID, because I think it's a problem that is underappreciated and not adequately dealt with in our society. It has myriad symptoms. There are lots of different definitions for this disease, but I think the bottom line is it represents persistent symptomatology past 2 months or 3 months, depending upon whose definition you're using. 2 months to 3 months past having your infection. And we don't know what causes it. And I think most people, and I certainly feel that there's probably multiple causes. And we need to figure out if somebody has long COVID, what may be the cause, because that hopefully in the future will inform an appropriate intervention. I won't go into all these hypotheses, but long COVID is just a constellation of signs and symptoms that is probably the endpoint of a variety of different insults to our body after having COVID. How frequently does long COVID occur? We're not sure. We see earlier on, I was seeing reports of up to 60 or 70% of people after having COVID. That hasn't panned out. Most of the reports today are showing somewhere between 5 and 30%. More of them tend closer to the 5% than 30%. But that's still a guesstimate of where we are. It's an enormous number of people when you consider the fact that there are about 100 million cases of COVID. People have had COVID in the United States, and I think that's an underestimate. That's talking about millions of people with long COVID. Few observations about this. Only about 15%, or as many as 15%, depending upon how you want to look at that, of people continue to have symptoms for at least 9 months or more. So if you get long COVID, you've had symptoms for more than 2 or 3 months. Most people by 9 months do no longer have symptoms, but still 15% do. Most people who have long COVID experience the effects of it, but they are not sufficiently significant to, for example, prevent work or prevent carrying out daily activities. But an awful lot of people can't go back to work still from this, or can't carry out a lot of their daily activities. Some other observations about COVID, long COVID. Interestingly, and nice to know that with Omicron, so beginning in December of 2021, with Omicron, we're seeing fewer cases of long COVID compared to Delta, which preceded it by a few months. So that's good news. We've consistently seen throughout the pandemic that women are more likely to get long COVID than men. There are a variety of hypotheses as to why this may occur. We know women, for example, handle infectious diseases much better than men. but we also know that women have far more autoimmune problems than men. So there may be something in that delicate balance of immunity in females that predisposes, but that's only a hypothesis. And the percentage of people who have long COVID have been, as I mentioned, declining since Omicron. So what are the implications? Well, it depends if your glass is half empty or full. It's a serious problem, even with the glass half full. But some people think it's going to be a mass debilitating event that's going to define economies of countries for decades. And on the other side, a lot of people feel that, yes, it's real, it's incredibly debilitating for the people who have it, but given the change in risk, it's not. It may not have a long-term implication for our societies. Nobody knows the answers to those two polls. The answer is likely somewhere in between them. So what about reducing your risk of getting long COVID? Well, the best thing to do is just not get COVID in the first place. I don't mean to be glib there, but I think that people often forget about long COVID when they talk about that they're not real worried about getting COVID. There have been several studies now that have shown that vaccines can reduce the risk of getting long COVID if you get COVID by anywhere from 15 to 85%. And there's one well-done study that suggested that if you take Paxlovid, I'll use the brand name, excuse me, it's just too much of a mouthful to use the generic nirmatrelvir, ritonavir, so I'll use Paxlovid. If you take Paxlovid, it reduces the risk of long COVID by 25%. So a person who's up to date with their vaccines, who gets COVID in spite of that, and takes Paxlovid, the chances of getting long COVID are dramatically reduced. So let's now turn to variants. We've seen quite a few. The last 13 months have been all about Omicron. That's all we're really seeing here in the United States and really worldwide. Omicron has been the most successful variant, and Omicron in these 13 months has spun off lots of subvariants, the most recent of which is XBB.1.5, which I got this picture from about a month ago or 6 weeks ago, and they didn't, XBB.1.5 didn't even make the chart, but that's now comprising about, about 60-something%, and I'll show you some data on that in a moment. So what's with these new variants? There are three things to think about when you hear about a variant or subvariant: how transmissible it is, and it's more transmissible. Omicron is more transmissible than any of its predecessors, and that each of these new subvariants is more transmissible than its predecessor. Right now, with the exception of the measles virus, the current subvariants of Omicron are the most transmissible respiratory virus human beings have seen. Immune evasion is the second thing to think about. How well can the virus evade the immunity we get from previous infection or vaccination? And each of these subvariants has been more immune evasive than the ones that we've seen before it. Fortunately, they all still respond to the vaccine, but the vaccine does not work as well as the virus evolves. So these are more immune evasive. And finally, virulence. How sick can it make us? And this is interesting. As I mentioned before, or I was talking about Delta, Omicron, while it's much more transmissible and much more immune evasive, it is less virulent than its predecessor, Delta. So we can feel fortunate about that. This tells us, of course, nothing about if there's a new variant, Sigma or Psi, and whether it will be more virulent or not. This is from the CDC each week on Friday, so I can only give you last Friday's report. It shows you what the modeling suggests in terms of the number of percentage of all of the variants that were circulating here in the United States. In this blue here, ending week of February 4th, XBB.1.5 comprises 66%. That's their estimate of the number of cases in the United States now due to XBB.1.5. So it is now the gorilla in the room. Let's talk about diagnosing COVID. And there's really just a couple of things I want to say about this. The only reason I wanted to show this chart for you, I promised not to teach immunology here, but I wanted to just briefly review the fact that when the virus enters our body right here, that the first thing the virus does is take over our cells and starts reproducing itself. And we can detect evidence of that by measuring the amount of viral RNA that's in the tissue we're sampling, for example, the nose. So early on, we get a lot of viral RNA, and it tends to peak relatively early on, usually peaking with Omicron within about 3 or 4 days of infection. And these viruses, the viral RNA is coding for the virus to produce a variety of proteins. For example, the spike protein that you hear a lot about. And there's a lag time between the viral RNA going up and then these proteins that we can also detect. So the proteins go up a little bit later and they go down a little bit sooner than the viral RNA. And that's the only take-home point here, because our diagnostic tests either are looking for RNA or protein. So these are the two commonly used tests. They're often called molecular tests or NATs, nucleic acid amplification tests, but most of the time we just hear them called PCR, standing for polymerase chain reaction tests. They detect the RNA. The other tests that we have, the ones that we talk about, home tests, they're called antigen tests, they're detecting protein. And so these are very different tests. They're looking for different things. And that tells us a little bit about how we can use them. Lots of questions. I'm going to go through these quickly, but if you have more questions, feel free to ask during the Q&A period. But let's say you've got symptoms of COVID. You wake up in the morning with runny nose, a cough, sore throat, ache all over, et cetera. What's the best test? Well, the best test would be the PCR test, because it's going to pick it up earlier than the antigen test will, as I showed you before. But PCR tests are getting harder and harder to find because our Congress will not authorize adequate funding for them. That's why I mentioned earlier, we're doing a fraction of the number of PCR tests that we were doing a year ago, which is just tragic. So we have to rely on antigen tests, and I'll come back to that in a moment. Let's say you've got COVID and you're wondering, what test shall I get to determine if I can come out of isolation? Well, you don't need a test according to the CDC to come out of isolation. But I wanted to tuck into this the idea that the PCR test remains positive long after you're contagious. It averages about 21 days, but some people can go out 2 or 3 months even with a positive PCR test, and they don't have COVID. It's just that the test is so sensitive to pick up the RNA of the virus that it's not a good test to use to answer the question, can I come out of isolation or am I still infected with the virus? The antigen test is a better test to do that because it correlates with the virus, the RNA producing the protein, and that's what we're looking for. But again, the CDC does not require testing. I think it's a good idea if you've had COVID after day 5 to do an antigen test. If it's negative, you can be pretty sure that you're not going to be contagious, but wear the mask for another 5 days. It's a good tool to use. And if you keep testing positive with the antigen test, I'd be much more careful for those 10 days, even if you don't have symptoms. Third question is, I've been exposed to someone with COVID. What test should I get? Well, the best test here would be the PCR test because it's much more sensitive. What test shall I get to determine if I can come out of quarantine? I mentioned that before. I've had COVID, I'm now well, but my PCR test is positive. Am I still contagious? I mentioned the answer is no. Is there a test I can get to determine if I need a booster? Absolutely not. There is no test that's commercially available, even though some laboratories that really are not being ethical have been advertising that they can do that for you. And I want to visit my grandparents. Well, I wish I still had grandparents, but people ask, I want to go visit somebody who's at higher risk. Can testing help? And the answer to that is yes. I think a rapid test just before you go over, if it's negative, is a pretty good indication that you're not going to be contagious for the next several hours. So it's nice to add that to our armamentarium, and I'll come back to that briefly. So what about treatment now? And there's really one thing I just want to stress, and that is that patients are not getting treated adequately. Too many people in the United States are not getting treated for COVID when they should be. We have several options, Paxlovid, remdesivir, molnupiravir, and I still have on this list monoclonal antibodies, but I'm going to cross it off. All of the monoclonal antibodies we've used for outpatient therapy now have been withdrawn because the virus is now resistant to it. So none of those are available any longer. This is particularly bad because there was a product called Evusheld that was great for people who could not produce antibodies if they got the vaccine. For example, they had some kind of immune deficiency or transplant when they were on chemotherapy for cancer. All these things would prevent them perhaps of getting adequate immunity with the vaccine, but we could give Evusheld and it would last 6 months. It's just giving people the antibodies they needed, but now the virus is resistant to that. Of the three, the one that people should get if they possibly can is Paxlovid, and you need to take it within 5 days of the beginning of your symptomatology. So it should be taken the earlier the better. There are only 2 drugs that are absolute contraindication for that. And one is very uncommonly used. The other is a fairly commonly used powerful anticoagulant, but you can be changed often to another anticoagulant where the drug can be used. There are many drugs for which their dose has to be modified if you're taking Paxlovid, either stopped while you're taking the drug or reducing the dose while you're taking it. And your doctor can advise you about that. So it's tricky, but you can take this drug with almost everybody can take it. If you can't take it, the next best choice is remdesivir. It works very well. The data on that is almost comparable to Paxlovid, which has about an 85% chance of reducing your risk of hospitalization or death. That's awfully good. Problem with remdesivir, it has to be given intravenously, so you have to find a clinic that's doing it, and you have to get it IV daily for 3 days. So it's a very cumbersome problem. There's another oral drug called molnupiravir. It reduces the risk of hospitalization and death by about 30%. So it's not as good as the first 2. But for somebody who can't find remdesivir and can't take Paxlovid, this is better than nothing. So who should get treatment? Anybody who is at higher risk for a bad outcome. I think that translates to anybody 50 or over. That's a large swath of our population. Anybody with underlying chronic health problems at any age, you have to be about 12 or over to get it. It's only the age for which it's approved. And we're not seeing, we're seeing a minority of people really who should be treated getting COVID, getting this drug. So this is a real problem, and there's been a real push to get physicians to prescribe this with more. The story I commonly hear is that I called my doctor when I had COVID, but I'm not very sick. And she said, or he said that it's just a mild infection. You probably don't need to be treated. That's not right, because I think and I've certainly seen so many cases of people. This virus can turn on a dime where you can not be very sick today and be really, really sick the next day. So that's not a good reason not to give the drug. People are real worried about rebound. So let me give you some numbers. If you take Paxlovid, this is one of the, I think, best designed studies. About 14% of the people got rebound who took Paxlovid, and about 9% who got a placebo. There's also symptom rebound. That is, you get your symptoms come back, but you test negative. That happened to 19% of people who took Paxlovid and 7% of people who took placebo. So it's more common with Paxlovid. Rebound is almost always the same or less severe than the original infection. But you are contagious if you get at least testing positive with rebound. So you have to go back into isolation. This is not a reason to hold taking Paxlovid, in my opinion. So how to prevent COVID? I think first, let me just say something about how this virus is transmitted. We've learned a lot in the 3 years. Ingestion, if it plays a role, it's a very, very minor role. It probably does not play a role. Inanimate objects, what we call fomites, that is, somebody's touched something that you touch. We know the rhinovirus, which is the most common cause of the common cold, can spread on fomites. It's less clear with influenza whether it does or not. We think that we're not sure whether the virus SARS-CoV-2 can spread on fomites. It's unlikely. I think washing your hands or using alcohol cleanser on your hands is still very prudent to do, but it's not a major way this virus transmits. This virus transmits in the air, either by droplets that are pretty heavy and fall to the ground, usually within about 6 feet, or smaller droplets that are very light and can remain in the air for several hours if there's not good air circulation indoors, and go many, many, many meters from that person. 30 meters is not unusual. So this is an airborne and droplet spread virus primarily. So you've probably heard, or you may have heard of the Swiss cheese defense. This is the idea that for the virus over here to get to you over here, it has to go through each of these holes and they're not lined up. And so if we do lots of different things, it's going to be very difficult for this virus to get to us. What are these things? Well, physical distance helps a little bit, but again, because it's airborne and can spread meters from that patient, many meters, it's not a big help. But staying home at sick can really be helpful. Masking is very, very helpful, and I'll come back and talk a little bit about that. Hand hygiene, I think, is, as I said, reasonable to do, but how critical it is it? I'm not clear. Frankly, it's nice not to get a common cold, so that's a reason in itself to prevent rhinovirus infection. And then cough etiquette, coughing into your elbow is much better than just not coughing. Not sheltering your cough at all. Avoiding touching your face. This is the idea that if you touch a fomite that may have the virus on it and you touch your eye or your nose or your mouth, you could spread it that way. It's reasonable. If it's crowded where you are, especially indoors, limit your time or avoid. Fast and sensitive testing and tracing would be very helpful, but we don't do enough testing. And we, because of that, contact tracing is not proven to be a very good tool. And this virus spreads when you're asymptomatic. It can be in your respiratory secretions for 12 to 24 hours before you become symptomatic. So it's very hard to use this testing and contact tracing effectively for this virus. Ventilation is really important. If you're going to be indoors, I hope you can be in a place where they have lots of air exchanges per hour. Outdoors is so much safer than indoors. Better government messaging. This is something we've really learned in this pandemic, not just in the first year, but I think that we still don't do a very good job messaging all of the aspects of this virus to the public. And this is something that requires improvement. And then finally, not finally, but quarantine and isolation is very helpful in certain circumstances. Vaccines, I'll talk about more, and I've talked about the pills already. So just briefly about masks. If you're going to wear a mask, wear one that works. We've learned in this pandemic that cloth masks really don't work very well at all. Surgical masks maybe work 50%. Maybe they're 50% as effective as the best masks. So if you're going to wear a mask, wear one that works. And the three that work the best are the N95, which is the gold standard, a picture of it over here. The KN95 is also excellent. The KF94 is just about as good. So wear a good mask and wear a mask that fits. For some people, the KN95 fits better than the N95. The KF95 fits better than the other two. Find one that fits you well of those three, and that's the one you should wear. And in regards to vaccines, there's some confusion about this. There's really two types of vaccines that are approved for use in the United States right now. The mRNA vaccines, which are Pfizer and Moderna and J&J. Very little use for J&J right now. And then what's called a subunit vaccine, which is the more traditional vaccine, Novavax, that was recently got emergency use authorization. So those are the vaccines we have. There's confusion about terminology. All of the vaccines up until the bivalent contained what we call the ancestral strain. That was the strain that broke out in China probably in November of 2019. And then by the time the virus got to the United States in January of 2020, it was no longer the ancestral strain. It had already changed. So we've never even seen the ancestral strain here. But the viruses that caused havoc in 2020 and 2021 were very closely related to that. Today, with Omicron and these subvariants, they're not very closely related to the ancestral strain. And that was one of the reasons why we produced the bivalent vaccine. The bivalent vaccine contains still the ancestral strain as half of it and protection against BA.4.5, which was the predominant subvariant in the summer. As I mentioned, now XBB.1.5 is. So the bivalent vaccine is what we've got now. What the FDA just, the FDA Advisory Committee advised the FDA to do for the coming fall would be to produce a either a monovalent vaccine that no longer contains the ancestral strain, or a bivalent vaccine, and they were stressing to use a bivalent vaccine that contained would not contain the ancestral strain, but would contain, for example, maybe XBB.1.5 with BA.5. And in that meeting last week, the advice was to give this annually, and I'll come back to that. Just a word about how well the vaccines work. This is for people who have gotten a bivalent vaccine in the orange, and people who just got the primary series, but not the bivalent vaccine. I just wanted to point out to you first that vaccines don't help anybody. It's only people who get vaccinated. And so too many people are not getting vaccinated. Only about 15% of the overall population of the United States has availed themselves of the bivalent vaccine. And most frighteningly, if you look at, excuse me, people 65 and over, it's just around 40%. And these are the people at the very highest risk of a bad outcome, and they haven't gotten the bivalent vaccine. So this is a public health failure that we haven't been able to convince the population who's at very high risk of getting the bivalent vaccine. And this came out today. It's actually dated tomorrow, but it came out today from the MMWR, Morbidity and Mortality Weekly Report from the CDC. Vaccinated people who received the updated, that is the bivalent vaccine, were 14 times less likely to die compared to those who hadn't been vaccinated. 14 times less likely to die. And compared to those who had received the original vaccines, including boosters, but not the bivalent booster, they're 3 times less likely to die. The bivalent vaccine has been a success, but this has not been well messaged to the public. And I'm going to skip over this for sake of time. wanted to just show you, this is the cumulative COVID-associated hospitalizations per 100,000 by age group. So we're looking at hospitalization rates per 100,000 people by ages. And look at I just circled the less than 6 months. The hospitalization rate for a child less than 6 months is comparable to somebody who is around 65 to 74 years of age. These children are at very high risk. And somebody who's 6 months to 23 months to 2 years is comparable to somebody 18 to 49. So I wanted to point this out to you because COVID is not just like influenza. This carries serious consequences for people who are our youngest in the society. So the vaccine questions that are going to be really, I think, on everybody's mind for this year are, what will the new vaccine schedule be? It's probably going to be, at least for this year in the fall, a booster for everybody. But what's not settled is, what about for people who are at higher risk, 50 or over, 65 or over, or have underlying conditions? Should they get one at 6 months after their last vaccine, which is, for me, is right about next month? We haven't had any guidance on this, and this is frustrating. And the reason for there not being any guidance is we just don't have a lot of data yet at this point. So this is something that I'm keeping a very close eye on. And I said, what about the rest of the world? You know, what the FDA decides is not just for the United States, because essentially the vast majority of pharma is here in the US. And so what the FDA decides is really going to have implications for the rest of the world. And I talked earlier about that we're probably not going to include the ancestral strain. There's concern about doing that because there's this phenomenon called imprinting. And if you have a question about that, I'll be happy to address it. So what do we hope for new vaccines? We hope that they'll have enhanced breadth of protection. That is, that they're going to be good for every possible variant. That's a reasonable hope. That they'll have longer durability, so we could get them like a tetanus shot every 10 years. And they'll have enhanced ability to block infection and transmission. That is, not only protect us against hospitalization and death, which they're doing a good job of now, but they'll also protect us against getting infected. If they can do that, that's going to stop the virus, because we saw that with measles. The measles vaccines prevents people from getting infected. And if people would just get vaccinated against measles, measles would go away. So let me conclude by just looking at a few words that we hear thrown around a lot. Eradication. This is not going to happen in our lifetimes with this virus. We've only eradicated one virus in the history of our species, and that's smallpox for human beings. So we're going to be left with this virus. Can we eliminate it? Elimination means that we've reduced the number of cases either to zero or near zero in a defined geographic area. So for example, polio is eliminated from the Americas. We still can see a case, and we saw a case last year of polio in somebody who was not immunized, but it's essentially eliminated. We see measles is eliminated, but we still see outbreaks in the unvaccinated. A big outbreak that was going on in Ohio was just, I understand, was just yesterday declared finally over. 85 cases, not a lot of cases, but 34 of those cases of measles people with measles were hospitalized. We hear a lot about the virus COVID now becoming endemic. And endemicity, or in the virus being endemic, means that it's at a fairly steady state and is predictable. This virus is not yet predictable, and it's not yet at a steady state. And I'll come back to that in a moment. And be careful what you wish for, because endemicity says nothing about how many cases are occurring. You could have an endemic disease with an enormous number of cases, but it's stable and predictable. Or you could have at a very low level, which of course we would much prefer. I'm going to skip over that. And so where are we heading? The gray is the interpandemic phase. So for example, this would be in the phase before COVID came along. We were between pandemics. And this would be very early in the pandemic, and then the pandemic phase. And where are we now? A lot of people think we're probably here in a transition phase. And that is, we're coming out of the pandemic phase of the disease, and we're entering perhaps a more stable time with the disease. We have no idea that that's going to happen, and we have no idea how long it will take. It could occur this year. It could occur in 10 years. So we are probably in a transition phase, but that does not mean that we're out of trouble with this virus. And so finally, where are we heading? There's a real tug of war that we've seen with scientists and physicians, typically on one side, leaders in public health, going from one side to another. It's been terribly confusing for the public. It's been terribly frustrating for everybody involved in this pandemic. And this is, I think, a terribly important lesson going forward. We all have to be on the same page if we're going to be successful. So thank you. And I'm sorry, I apologize for talking longer than I intended. And I'm happy to take questions.
Good. Yeah, we have some questions in the lined up in the chat. Maybe Corinne, you had a question about different kinds of masks. Would you like to ask that question?
Hi, yes. I have a small face, and the children's masks that I've tried are too small, and the any N95 or KN95 too big. So I found one that's an M95C made by Lutema, but I have no idea if it's as advertised. So are there any thoughts, or does anyone found a good mask for a smallish face?
It's a terribly important question, and I don't have an answer for you. If you email me the product that you're talking about, I will see what I can find for you. My email address is jes@berkeley.edu.
I have a small face and I get a well before mask, and they have a small adult. It's not a kid's. So
Thank you.
it's well before, and they're NIOSH approved.
Well, there's a great answer for you. Thank you.
Thank you so much. Appreciate it.
Good. Thank you. Irene had a question.
Right, I do. So I have long COVID, and I had a very peculiar thing happen to me. I had probably the BA.5 variant in June, recovered by July 4th, and went off to the mountains to go hiking for a month, had a fantastic time in the mountains, no problems, hiked 8 to 10 miles a day in 10,000-foot elevations, and came home, and within 3 days, I couldn't walk around my block, and eventually realized, yeah, this is long COVID, and I'm still in it. So the question is this. So at first, Kaiser said, you can't have long COVID because you had a month of good health. So I've had an acute ear listening for the distance of time between recovery from acute COVID and the onset of long COVID. And I'm hearing many people have that real, so I would love an explanation for, what is going on that you can have this very healthy period and then boom, you're in long COVID.
Yeah. Well, first of all, I'm really sorry that happened, and hopefully it will get better and better and better. Are you improving?
I am improving quite a
Good.
bit,
Good.
but I crash regularly. Yeah.
Yeah. We don't know what's going on. You know, I had that slide with the various hypotheses as to what's happening. We know that I mentioned earlier that the virus can involve multiple organs. The and we're finding now reports of the evidence of the virus all over the body.
Mhm.
And one of the, I think, very tenable hypotheses is the idea that our immune response keeps attacking those, the virus wherever it is in the body.
Right.
And that chronic low level of inflammation is what's causing the symptomatology. There, as I said, there are a variety of hypotheses for this. But you know what, from what you're describing, that period where you had COVID and then you were fine and completely recovered, and then something happened, that would fit in with that model of your immune system continuing to attack. And sometimes the virus may be long gone, but your immune system just keeps at it.
Yeah.
But your problem, what you're describing, is that latent period before you got long COVID is very classical. I mean, some people get COVID and just remain sick and then just doesn't go away. That's very typical too, but there's nothing atypical about what you're describing. The reason why you were probably told that is because this is, our knowledge, we've learned an enormous amount in 3 years, but we're just still scratching the surface.
And so anti-inflammatories are ways of tuning down the immune system, if that's the theory, just to see if that works. Is anybody in one of the recover programs trying that?
There are trials of that going on with a variety of different anti-inflammatory agents. There are trials of taking Paxlovid. There was just one released that didn't turn out to be very successful, but there were some hints that it might be in a different group. There are lots of different centers are having a variety of trials. Both Stanford and UCSF have very good long COVID clinics.
Right. Thank you.
Thank you. Audrey had a question.
Yeah, it was actually me, Roger.
Hi.
I was just struck with the difference between the responses of different countries around the world, and I was wondering if there were any of them who have handled it well, and what worked better.
Yeah, thank you. That's an important question. We need to learn. I think South Korea did very well. Actually, Japan did very well up until recently, when it's struggling right now. What we saw, societies that tended to have more trust tended to do better. Societies that had a healthcare system that covered everybody did much better. Those, I think, are probably two of the most important aspects, and you'll note those are cultural phenomena as opposed to, quote, medical phenomenon. But I think that those are two lessons that I've paid particularly close attention to. Just if you look at just masking, for example, about 5 or 6 years ago, I was giving a series of lectures in Taiwan, and I noticed that there were lots of people, not just indoors, but outdoors, wearing masks, which has been part of the culture in not just in Taiwan, but in a lot of the Asian countries. And anybody with a cold would just put a mask on. And that's one example. And then you look at the United States, and where masks are politicized, which frankly is just insanity.
Excuse me, what about the question of opening up versus shutting everybody down? It seems to me like there are some countries where they started by shutting down, and then once the vaccines became available, then they opened up more, and that seems to me intuitively to be a good strategy.
It is a good strategy. It's trying to hit that sweet spot between shutdown to make sure the virus doesn't overwhelm, and then get everybody immune as quickly as you can, and then you can start to open up again. And at the same time, not just the vaccine, but make sure you have the adequate health resources for your healthcare workers and for the population. That is adequate hospital beds, ICU beds, masks for and other protective equipment for the healthcare workers. In other words, be prepared during that period of time when you shut down. The one thing that threw a monkey wrench into that was if the vaccine itself protected against infection, that is prevented transmission, this would be a fabulous strategy. And initially it looked like that's what it was doing with the ancestral or the close to the ancestral strains, but with the vaccine not giving the kind of protection we had hoped in terms of preventing infection and preventing mild disease, you'd have to have a strategy with the vaccine to keep making sure people are adequately boosted as you opened up things. And then it doesn't account for the virus itself becoming more immune evasive. And that's what we saw with Omicron. We got a population that was fairly well immunized going into Omicron, and then it just overwhelmed the population. So it's a combination of all these things. We've got a lot to learn. Your question is great.
And Jane's queued up first, and then Sally.
Yeah.
Jane?
So I recommend this mask. It's called Ergami. And it looks like this. And it's very comfortable. It only touches the rim. It stays off your face. And you measure it. You measure from the bottom of your nasal bone to the bottom of your chin and the width of your mouth. So you can get a size that works for you. So you can learn about it online, Ergami.
Thank you so much.
Jane,
Make
thank
sure-
you. Thank
Make
you.
sure you check and see how well it filters and the electrostatic forces. Because
Yeah, it's an N95.
Okay, great.
Good.
Sounds
Thank
great.
you. Well, you put the name in the chat, maybe. Okay, Sally.
Yeah, I had a question about re-wearing N95 masks. Somewhere I read that you could clean them with peroxide between wearings. I don't know. Can you re-wear them?
Yeah, you can. Initially, we didn't want people to re-wear them, but that didn't make sense because we didn't have enough masks for the doctors and nurses. And so doctors and nurses were re-wearing them from the beginning. I think it's perfectly fine. If they get wet, you can't continue to use them because you lose the electrostatic protection that the masks afford. But if they're clean, they're perfectly fine to rewear. How many times can you rewear them? Nobody's really sure. Some people say a week, some people say 40 times. So I think that it's fine to rewear them as long as they're not dirty and they fit well.
Okay,
It's-
but
they're not wet.
do you destroy them by wiping them with a very dry, damp cloth with peroxide on it?
No, you know what you can do if you're worried about the virus still sitting on there, you can just let it sit out for 2 or 3 days and wear another one.
Rotate.
The
if you-
virus, yeah, you could rotate them, so the virus would be dead anyway.
Yeah, okay, great. Thank you.
Sure.
Linda has a question.
Hi, John.
Hi, Linda.
Good to see you. Can you speak to the risk of reinfection for the elderly and also for the elderly who have had or have long COVID? In terms of whether the infection is more serious, whether the risks of hospitalization and death are higher, and how we're supposed to live and protect ourselves.
Yeah. So unfortunately, reinfection is common. And that's because of waning immunity that I was talking about earlier. Each reinfection carries a comparable risk of getting long COVID. So a lot of people think, well, I had COVID and I didn't get long COVID. I'm home free if I get infected again. The data that we have, it's relatively recent, is pretty compelling that each infection carries a risk of long COVID that you're not protected because you didn't get it with the first infection. So if you've had COVID twice, you've doubled your risk with the second infection. There's nothing about having long COVID that makes you at greater risk that we've seen for getting reinfected or having a bad outcome. That said, people with long COVID, there's some preliminary data that suggests that people with long COVID may be at greater risk for a shortened lifespan. Some people with it. We don't know that for sure, and it's because as I said, long COVID is just a description of people with persistent symptoms, and it's probably most certainly has multiple causes. If you've had long COVID and one of the problems was that you had blood clots, well, you can see where that would shorten your lifespan.
Susan and Sandra?
Yes, I'm like all of us, an older person, and I have 5 or 6 comorbidities, depending on how you count. And I've mostly just stayed home for the past 3 years and been really careful about wearing a mask when I was around anybody other than my partner. So do you have any, but it's getting to be really hard to do that. And so I'm interested if you have any guidance on how you evaluate my risk and how far into re-entering society I can go.
Yeah, I have my consultant here next to me now. I'm asked this question all the time, and I'm negotiating the same question. My wife's negotiating the same question. There's no one answer. It depends upon your risk tolerance. And here, well, that's not a very helpful answer. Here's what I do, and it's best I can do. I don't want to get COVID. And so I look at everything that I'm doing and try to weigh the risks of that versus the benefit of doing it. So going out to dinner with friends to a restaurant, we do that, but we talk to the friends before and say, just please don't come if you have any symptoms at all, even if you just think it's allergies, and we'll only eat outside. There's a little bit of a risk, but it's very, very small, particularly right now. And I do look at what's happening. If this was January of 2022 with Omicron just surging, I was not leaving the house. But it's a very different pandemic right now at this moment. So I pay attention to what's happening as well. If there's an occasion that's terribly important for me to do, that I just don't want to miss it, I will do that. But I'll wear a mask if at all possible. And if it's going to be dining at the same time, that really makes it harder for me to do it, or it means the occasion would have to be just that much more important. So that's how I've been navigating my life right now. I have colleagues who I respect greatly at UCSF and at Berkeley, who are far more, who are one of them is my age, who are not wearing masks when they go indoors and dining indoors and doing everything they want to do. And I have some colleagues who are even more cautious than I am. It's getting harder and harder, as you said. And this is, we all have to navigate it best we can. I'm sorry that I can't give you a better answer. I struggle with it too.
Can
And
you
let me just say one last thing. You mentioned your partner. I may have my own risk tolerance, but my partner may have a very different risk tolerance. And so, for example, I may be saying, well, I'm fine with doing that, but my partner is not. So I'm not going to do it. So or if it was that I was living with someone who was immunocompromised, that would change the calculus tremendously. So all these things go into your calculus. There's no right and wrong, I don't think.
Thank you. Thank you.
Irene has mentioned in the chat about nasal vaccines and their hope for reducing or preventing transmission.
Yeah, I know Eric Topol down at UC San Diego keeps yelling and yelling about that. If we can get them to work, they would be a godsend, or maybe a combination of the shot plus the nasal vaccine. But we haven't gotten them to work well. What we should be doing, and we're not doing, is we should be throwing a ton of money at developing them. I think it could turn out that we'll waste our money, that we can't figure out how to do it, but they have tremendous potential, because if you've got good immunity in your throat and nose, and that's how the virus enters our body, it's not going to infect our cells, which means it can't reproduce in us, which means we can't infect somebody else. So, yeah.
And Amy has a follow-up question.
Thank you, Dr. Swartzberg. And I want to thank you for when you helped that mayor a couple of years ago figure out about the outdoor parade.
Sure.
We're forever indebted to you. Quick question, if I can ask a corollary on your risk reward calculation, talking about restaurants, what about travel?
Yeah.
What's your thought, both whether it's Europe, US travel, California, US, Europe, or developing nations? What do you think?
I think you have to, if you're otherwise healthy, are reasonably healthy, I think you can travel with a pretty good degree of safety. Mm-hmm. When I say travel, I mean, my mind is going to, how am I going to get to the airport? What am I going to do in the airport? What am I going to do in the plane? And I think we have some control over that. Hopefully one of my kids could take us to the airport, that I would wear a very good mask. I'd wear an N95, it fits me well. And I would leave it on in the airport, and I would leave it on in the plane. I'd maybe take it off to get some sips of water, but I'd hopefully be able to keep it on almost all the time in the plane. Speaking of planes, they've got very good air exchanges, 10 to 12 air exchanges per hour, sometimes even more when they're in the air. When they're on the tarmac, they have 1 or 2 air exchanges per hour. Terrible. So the biggest danger on the plane is when they're on the tarmac and you're stuck with all these 300 people, of which some are going to have COVID just by statistics. So I think we have control over those things, but then where are you going? And what's COVID like where you're going, and what are you going to be doing while you're there? Most of the people that I've talked to have gone to Europe this summer, for example. A lot of my colleagues and friends, they didn't get COVID from the plane. They got COVID from the stuff they were doing when they were there. So those are the kind of questions I would ask. I'm hoping that I'm planning, we haven't been back east to see our daughter and her family in DC in 2 years. So I'm planning on doing that this spring if things remain quiet.
So if I may follow up on just one aspect of that, how about Paxlovid? Some friends are going and they're getting a prescription filled ahead of time.
I know they weren't supposed to do
5 days. I know. So what do you think? Especially going to a foreign country where it's not like going to, staying in the United States.
Yeah, I would. Well, the good news is, doctors weren't supposed to prescribe Paxlovid unless you had COVID. The good news is that just changed, I think it was a week or 10 days ago.
Okay.
So now you don't have to document that you have COVID to get a prescription. So I would not travel without carrying a prescription of Paxlovid with me. And I would not travel without carrying some rapid antigen tests with me. And the minute that test turned positive, I'd start taking the Paxlovid.
Great.
Thank you.
Thank you so much. Thank you very much.
Sandy has a question.
Yeah, I have heard that there are never COVID people. Can you speak to that? And what
Yeah,
would be a never COVID person?
I'm a never COVID person. I've never had COVID.
I never have either.
Yeah, so we're never COVID people, but we're probably never most of these people are never COVID because they haven't been doing things to get COVID. You've probably been very careful.
Some people's immune systems are
Right.
pre-treated to resist it.
There are probably some people who are resistant to this virus getting infected. There are some people, probably less than a few hundred, that are resistant to getting HIV infection.
Mhm.
Maybe it's a few thousand. But the vast majority of people who've never had COVID have never had COVID because they haven't gotten infected with it. There probably are people that can't get infected with it, but you don't know who you are, whether you're one of those people.
Right.
Yeah.
Well, you survived the flu epidemic of 1917. I was wondering if that could have given me some enhanced immune system. I've been told I have a great immune system.
That's wonderful. But most people survived the 1917, 1918 flu pandemic. It only killed 2.5% of the people it infected. And that translated to around 50 million people worldwide in about 14 months.
Sandy had a question about getting revaccinated after 6 months. If you got the vaccine in September, can you get a vaccine in March or April?
It's not approved for that use yet. That's what's so frustrating. The CDC advisory committee is meeting at the end of this month. And I don't know whether they'll be addressing it or not. I hope they will. If not, I know that it's going to be addressed by May or June when the advisory committee meets again. But right now, if you've had the bivalent, it's not authorized to be used again.
I don't see any more questions in the chat. Anybody else want to raise their hand?
Well, with that, it's 4:30. Doctor, you've been more than generous with your time. We really do appreciate it. And thank you one last time for speaking.
You're welcome.
Thank you.
My pleasure. Goodbye, everybody.
Bye.
Wonderful.